So here's the goals. We're going to talk about behavioral symptoms associated with dementia. So sometimes when someone has a medical issue, it may be manifested with psychiatric symptoms, which is agitation, irritability, maybe even something a little bit more severe like violence. So always keep in mind, let's think of all the medical things that could happen to a patient before we think of, hey, is this something psychiatric or mental health related? We'll talk about what the DICE model is in regards to how do we handle behaviors associated with dementia. For example, wandering or, escaping, maybe even hitting. So just good strategies in regards to that. The importance of how to describe these behaviors, we'll go into that. How to document these behaviors. And I know your administrators will talk about that more in regards to documentation purposes. Okay. And we'll go through, again, just an overview of dementia, and Howard will talk about depression in the geriatric population or psychosis. Sometimes depression looks like dementia. And as a physician, the first thing I do is assess for depression if I see someone's having memory problems. And you'd be surprised, sometimes with medication or other conservative measures, helping with depression also helps with memory. So always start with that from our endpoint. Okay. And we'll talk about what we do in regards to medication management, because you'll see a lot of interesting medications, a lot of medications that our geriatric population has. So it'd be important to know, how is this impacting their behavior? Is this a side effect? When's it a good time to tell the doctor, hey, like, what's going on? Or, Okay. So BPSD so this is the behavioral and psychological symptoms associated with dementia. So does anyone would anyone want to tell me what they think BPSD symptoms are, or from personal experience, from work experience, what these behavioral and psychological symptoms of dementia may be? We talked about one of them briefly, which was wandering, potentially. Yes, memory loss. That confusion could cause a sense of distress, right? Anxiety, and that anxiety can make someone go like, what's going on? Why am I here? Why am I not home? Why am I locked here? And then want to leave. So yeah, memory loss is a core thing. And we'll briefly touch on this too, but just because someone has lost their memory, they still have, there's an emotional intelligence component that obviously still remains. The way patients, our population, may experience anxiety, sadness, distress, that's still there, but it won't be manifested the same way a young adult population, for example, may show. Okay. So, Howard, do you have anything you'd like to add? And okay. So it's very important that we treat these behaviors and we look at simple things of what we can do, and we'll talk about those simple things. So the first thing I look at is the environment. What's going on with the patient? So for example, is there adequate lighting? Is it too noisy? Stuff like that before I even think about medication. So from a psychiatric standpoint, I always like starting from a conservative approach, okay? But it's important to identify these behavioral and psychological symptoms of dementia that may be harmful for the patients because it reduces their quality of life. They may be over-medicated as a result, for instance, or put in a facility that may not meet their needs for their level of memory loss. Their quality of life for the caregivers is going to be hard. So it's important to help educate the caregivers as well, so it doesn't contribute to their fatigue. It's very difficult taking care of someone with cognitive issues for the caregiver, so we always think of them as well. Early nursing home placement, hospital admissions, morbidity, again, going back to that quality of life, it's very important. Mortality, how long someone may live because they're having these behavioral issues. Okay, so here are some common behavioral problems. Wandering, we talked about that a little bit, but restlessness. What do you think restlessness will look like in someone with some cognitive loss? They're in a semi-locked facility. What would that restlessness look like? from a behavioral standpoint.
Cannot stop moving.
Yeah. Yeah. So not everyone's going to be seated. We would want everyone to like, hey, sit down, enjoy your food, enjoy conversations. No, there's some restlessness potentially where people just want to go. And you could tell pacing is one of the first things I notice within that patient population, just walking, up, down, and not being able to kind of sit still, right? Which is different than wandering. It's somewhat similar, but it contributes to it, wandering, leaving the environment, refusing food, right? So this is why, as a psychiatrist, I'd want to know, how much is my patient eating? Are they using the bathroom? Again, simple things, because maybe they won't be able to communicate that. Not having a bowel movement for whatever someone's normal may be could cause a lot of distress, and they may not be able to communicate that, so that causes them to feel restless, right? Sleep disturbances, so that's key. If you fix sleep, you fix a lot of things in your life, right? So sleep is key. So I want to know what time the patient's falling asleep. Are they napping throughout the day? Are they staying asleep throughout the night? So if that's kind of disturbed and they're pretty much sleeping during the day, awake all night, I want to know those things. So if you're not sleeping well, that could lead to combativeness. Has anyone heard the term sundowning here? Okay. So what's your understanding, if someone could tell me what is that term? It is a term I don't like to use, but it's a term that, that happens. The official term for it would be delirium, right? So what would you say an example of that is, or what is your understanding of what that is?
Like the symptoms start being more noticeable as the day goes down.
Mm-hmm.
In the afternoon, when sun is down.
Mm-hmm.
When they become more symptomatic.
Yes. More confusion. Okay. And it's hard to tell, because dementia is something that happens progressively from a long period of time, and this sundowning or delirium happens in a moment, very quickly, and it changes day by day as well. But yeah, so if someone is going through that, they're going to be very disinhibited. They're going to be combative, right? Which is different than how they may usually be. So that's important for us to know as physicians, or even for your standpoint as well, especially in regards to placement, how you're going to offer specific services to the patient. So is their behavior under control? Basically, that's what I'm trying to say. Now with dementia or any neurocognitive disorder, as they progress, there is a level of what is called disinhibition. So what that is let's say I have a thought in my head where it's like, okay, I'm going to go do this because I want to do it. But then I stop myself and I go, well, that's not right. Maybe I'll get in trouble if I do this, or maybe this is not safe. So someone who's had a neurocognitive disorder and has that disinhibition where we do our executive functioning in our brain, the way I like to think of it, there's not that filter that stops you and goes, hey, that's not cool, that's not right, that's not safe. So they may do something that may be potentially dangerous, or say something that may be hurtful, So we all have thoughts in our head where we go like, whoa, that person's whatever it may be. So someone who's disinhibited and has a neurocognitive disorder will tell you straight to your face, like, this is what's going on. And it's really hard not to take it personal as well, but it goes with that disinhibition component of it. Hypersexuality. It's connected with this disinhibition component as well, where some patients may be hyper oral fixated, may be very sexually sexually focused. So that's something to keep in mind, because that could be a danger to their peers or staff members as well, okay? Irritability, we've discussed that. And Howard's gonna talk about depression and kind of tease out, okay, is this apathy? apathy, like indifference because the memory loss is getting worse? Or is this like sadness? Or both? You could have both as well. Psychosis. Again, Dr. Howard will go into it in detail, but psychosis, let me briefly talk about that. What is your understanding of what psychosis is? Or just a symptom of being psychotic? Yes, hallucinations. Hearing things that may not potentially be there, seeing things that may not be there. A lot of patients with neurocognitive disorders may see things that are not there. So usually what I ask them, do they see a shadow from the corner of their eye? It's somewhat common with the disorder. Sometimes they see little spiders that may be at the edge of their bed. So if that happens, I'm trying to go with like, is this associated with the medication? Is this the sundowning? Is this part of their neurocognitive disorder? Is this something completely different? But it's going to be something common that you'll hear, you'll see. And other things that may be kind of psychotic is paranoia. You know, are you stealing my money? You know, that's a common, thing that you hear, that they blame their caregivers and say, you're stealing my money, you're hurting me, or something along those lines. It's important to do our due diligence and always confirm, is this legit? Is this right? Or is this part of the process, right? Okay. ADL refusal. So do you all know the activities of daily living? Did someone kind of break down, these are the activities of daily living, like in your courses? Yes. Do you mind saying it to the group?
Yeah.
Just so we're all on the same page?
It's like the things that we do every day, like bathing, feeding, getting yourself dressed, sexual activity, meal prep, things like that.
Yeah.
Or is all those things. Showering, brushing teeth, hygiene.
Yeah, so that's what when I do an assessment, I ask the caregivers and I ask the patient, are you having trouble eating? Like, are you able to eat, right? Are you able to use the toilet? Are you able to get up from your bed, transfer, go to your walker and or wheelchair or whatever you use to walk, to go to the bathroom or wherever you need to be? You know, are they able to dress? Sometimes dementia can get so severe, some people have trouble dressing, using utensils to cut their food. So that makes me understand, like, oh, wow, it's a little severe of what's going on. And have you heard of IADLs, independent activities of daily living? Can you all just tell me so we're all on the same page? IADLs? IADLs, yes, independent activities of daily living.
Like cooking, doing laundry, or shopping, stuff like that.
Yes. So this is a little bit different than the activities of daily living. So it's not like the basic necessities, how I'm going to feed myself or, provide shelter, bathe, etc. Independent of activities of daily living correspond more with your executive functioning. So that's like, again, like paying your bills. Are you able to call and make an appointment for yourself? So we assess for that as well, because that helps us know what services or support does the patient need. Okay, so that's something, if you want, look it up on the side, because it's a good breakdown of where the patient's at. IADLs and ADLs, like what are they able to do? How can I address this? And where are they at with their dementia maybe? Social withdrawal. So again, this is going to be hard to tease out, but I think important to know is with depression, with dementia, there may be a component of apathy, just this indifference where it's like, I don't want to do anything. I want to sit here and I just want to watch my TV. I don't want to talk to you. I don't want to take my meds. I just like, I don't want to use the word resignation, but just like don't care, right? And again, agitation and aggression. Those are the things that I'm worried about, because I would have to use medications to protect the patient's safety and their safety. The most common phone calls I may get from family members and or these facilities are, wow, the patient is being very agitated, they bit another staff member, or, they're hurting another peer within the facility. So having that under control as a physician is important, and that will help our other team members place the patient. Before I move on to the next slide, any questions or anything you'd like me to talk about a little bit more? Okay, good. Okay, so the DICE approach to psychological and signs and symptoms of dementia. So just briefly, we'll go through it. You just describe what the symptoms are, you investigate what's causing this, and then you create a treatment plan. Okay, so it's important to communicate this with caregivers and anyone who has interaction with the patient. So what's going on? So the patient became agitated. They're having a behavioral problem. What's important to think about? So basic things, right? Are they using the bathroom? Okay, so I'm investigating. Is there enough light in their bedroom? You know, it's important to have natural sunlight. Is their bed comfortable? Are they in any pain? Have they moved? You know, stuff like that. Do they have their hearing aids? It's very important that they get that stimuli, because if you're not hearing well, you're gonna be angry, you're gonna be irritated. It's completely reasonable. If you're watching TV and you don't have your glasses because the patient misplaced it, it's important to know, like, oh, they can't see. Completely reasonable to be irritated, right? Can't see the TV, that's part of your routine, or can't see the people they're talking to. So just important to know, does the patient could they hear well? Could they see well? Are they in any pain? Okay. Also, how this affects the patient, obviously. We briefly described that, and how that's affecting their caregiver as well. Okay. Any particular examples or anything that you may have experienced recently that you'd like to share in regards to assessing a behavioral problem and what your thought process was to break it down? If not, we could just go through this. But if there is, please email me. I'm more than happy to kind of break it down. So again, communication may be hard for certain patients within this population. And they may not be able to say, hey, I need to use the bathroom, okay? Or I'm in pain right now, or I have this rash here, you know? So first thing first, if I'm seeing a behavioral problem change, I wanna make sure, before I even think of psychiatric components, I think of medical stuff, right? So I'll try to help with the constipation. I'll try to help with, is there a UTI, a urinary tract infection? You know, because a patient may not be able to say, hey, it burns when I use the bathroom, or I haven't gone in a couple of days. So it's very important that the staff and I and the rest of the team kind of like document, oh, they used the bathroom this day or whatnot. Or if they missed a medication. So if they're missing their meds, their blood pressure goes up, or they have a headache, they may not be able to communicate that. So again, this investigation, and we do this as a team. Very important that, you know, social work, nursing, OT, PT, we all work together in these interdisciplinary rounds, and we kind of figure out like, hey, this is what's going on. The more data I have, the better it is for me to address what's going on with the patient. And boredom. That's key right there too. So let's say I ruled everything out, I'm addressing their psychiatric. Boredom's a thing, right? A lot of my patients, you know, sit and think of their entire life, right? If they have that cognitive ability, and most people do have that cognitive ability from like a statistical standpoint of having their long-term memory, and they think about, you know, their relationships and whatnot, and that could make them feel sad. So, and maybe their family members are not visiting. So this is why I like to tell my patients, hey, you know, make sure you have a calendar in your room, photos, have these different worksheets or whatever they can do to keep active, interacting with their peers even though they may not want to. So the more stimuli they get, the better it is. Okay? And then responding appropriately. So again, I think we kind of broke down what those signs were, this agitation, this sleep disturbance, this irritability. Do you see that? Let the other team members know, let the physician know. So if we tackle this problem early, we could prevent a hospitalization or more caregiver stress or even discharged from a facility and then they have to go to another facility because their behavior wasn't under control. So getting those early signs down is important. What questions do you have? I'm just going to stop here for a moment. Dr. Howard, anything to add? No? Okay, good. Okay. Now, this is more about COVID-19, but I do want to break down what's important for us to communicate with the caregivers. And we do this as a team, and the more reinforcement the caregivers get from us, the better it is about everything we just talked about. Where it's like, hey, if you see these signs, call the doctor. Or, hey, it's important to make sure there's like visits. Can you bring photographs? Does the patient have glasses or hearing aids? You know, do they have their dentures? Just getting that basic information. Because if they could do that at home, for example, if the patient is living at home, that could prevent problems that may lead to, again, hospitalization. And also asking the caregiver how they're doing. We don't really, a lot of teams, we try our best to address like, hey, what's going on with the caregiver? What are they experiencing? It's really, again, it's very difficult to take care of anyone with medical and psychological or neurocognitive issues. Okay. Now, I'm just gonna go through these symptoms and we'll kind of go through Alzheimer's a little bit. There's different types of dementia. So there's Alzheimer's disease. That one is, again, really quick. What we say, it's like rapidly progressive with memory loss, with rapid forgetting. So someone may be having a conversation with you and then they just forget and may ask a question. So it's very nuanced. There's different symptoms, but it is one of the dementias. The other dementia is what's called vascular dementia. So if someone has a lot of, vascular issues, for example, smoking, high cholesterol, multiple strokes throughout their life, that affects how much blood the brain gets. And the more it affects it, the more people may have some memory problems as they age. And then there's other dementias. There's something called a Lewy body dementia, where it starts off with seeing little things here and there. They start moving slowly. Parkinson's disease may have it. So there's various types of dementias. But with these dementias, there's similar symptoms that we describe, the behavioral symptoms that we have to be all as a team look out for. So months before diagnosis, this is just for Alzheimer's again, this is what the data at the Journal American of Gerontology or Geriatric Society Medicine found. One of the first symptoms is social withdrawal that they see before they're diagnosed with Alzheimer's disease. So when someone's socially withdrawing, and we've seen a lot of patients or even potentially family members where they're like, I'm not coming to this event, that seems normal, right? That seems normal. So it's really hard to kind of tease out what is a social withdrawal about. It could be depression because some people don't feel physically healthy or energetic to want to get up, have that motivation to get dressed and go to a family member's house outside of their home. It takes a lot of energy and effort to do that. So there may be a component of it that's normal, but it could be depression. And I don't have enough data at this point right here for me to go like, hey, is this some start of a dementia process? But yeah, most patients have depression before their Alzheimer's disease diagnosis. This doesn't mean everyone with depression at that age group is going to develop a cognitive issue, but you need to treat depression in that age group because it can lead to memory problems all by itself. And with depression comes suicidal ideation. And suicidal ideation is where someone wants to actively kill themselves, where they say, I want to kill myself, versus something which is called a passive death wish, which is more about, I just want to die. I want to leave this world. I'm done. I lived my life. So you may hear comments like that a lot from the geriatric population or anyone who's actually depressed. And then paranoia. So when it comes down to paranoia, it's important to confirm, always, some things may be true, right? Where they say, my caregiver is hurting me. Okay, so that could be paranoia, but it could be completely true. So again, doing our due diligence of knowing like, hey, what's going on here, getting the data that we need. Okay. Diurnal rhythm, and what that's basically saying, they have sleep disturbances. So it's completely normal for when we age, our sleep cycle, our 24-hour circadian rhythm to kind of switch. So people like sleeping in at 5 p.m., 6 p.m., and then waking up at like 4 a.m. That's completely natural. Your clock kind of shifts back. And everyone has like a different biological like clock in that sense. So there's switches. They may, it's harder for them to fall asleep. They may not stay asleep as long. So that's also tied in with depression as well. And then anxiety. Any idea of how anxiety may manifest? We talked about this restlessness, but how would this manifest? How have your patients demonstrated anxiety before their memory gets worse?
They get very worried over things that they know themselves worried about.
Okay. Like what?
It's like small everyday things. They might get very worried about taking care of their finances, their children's well-being, their grandchildren's well-being, their own physical health, that kind of stuff. And it's something that we typically haven't seen before from this particular patient.
Yeah, so, you're starting to have some memory problems, and someone's having memory problems, but they still recognize like, oh, it's hard for me to pay my bills, or it takes me longer to figure out how to deal with my taxes, or the amount of effort or energy it may take to kind of coordinate. And it's really hard navigating the health system. It really is. Calling an insurance, calling the pharmacy, making appointments. So when that happens, people go like, what happened? Like that sense of frustration. And then driving becomes a little bit more difficult. And then what if they do get that diagnosis of Alzheimer's and their license is taken away? That sense of freedom is taken away. These are all very distressing things. And then the stuff on the right is if they're diagnosed with Alzheimer's, and let me just quickly go through how I would diagnose it. Again, data is key, data is king. I talk to family members, talk to the patient, of course, get head imaging, assess for depression, assess for medical problems. Thyroid issues, for example, could lead to memory problems. If I figured out or like ruled out everything that could affect someone's memory, and I get that head imaging, then I'll feel a little bit more confident of going, okay, this is a neurocognitive memory loss issue as opposed to something else. So we literally go through everything, every organ. We like try to see if, hey, is something going on. You'd be surprised. Some people with thyroid problems may not know that they have thyroid problems, and we treat them with the thyroid medication, and their memory gets better, their mood gets better, their energy gets better. So we do our due diligence from a physician standpoint of, okay, what can we do? What questions do you have? I'm gonna think. That's good. Okay. So yeah, we kind of went through this, right? All the medical stuff that could happen that may contribute to memory loss. But this is specifically talking about delirium. So again, there's dementia, this chronic memory loss that happens over years. And there's different types of dementia. There's different stages. And then there's delirium. Delirium could happen, it's acute, usually happens in patients who are in the hospital. So let's say there's a patient, geriatric, they get a urinary tract infection. They're in the hospital, so they're not at home anymore. They have an infection. They're in an unfamiliar environment. They're hearing all these beeping. People are coming and opening the door at 4 a.m. so they could take your blood pressure. All this stuff is happening. They may not have like their hearing aids, their glasses. They're in an uncomfortable bed. Who wants to be in the hospital? No one wants to be in the hospital, right? So that could cause a lot of confusion. So the way I like thinking about it is, imagine how you and I would be if we get COVID, right? Imagine you get COVID and then someone says, hey, go to work the next day and write this like 10-page report. It's gonna be really hard to kind of use our mind and our cognition to go and sit there. Who's gonna wanna sit there and write a report, right? So imagine someone who has less of a cognitive reserve because of normal aging, right? And they have an infection and they're in an unfamiliar environment. They're gonna be it's likely they may be very confused. So someone has delirium, I try to see what's causing it. Low blood sugar, all these different things. We talked about constipation, urinary tract infection, pain, depression. We talked about the psychological or the environmental factors. So the first thing I do is when I go and see a patient in the hospital, I go and open the blinds. I want that natural sunlight in. I talk to all the staff members and say, hey, if you don't need to get the blood pressure during these times, let's not get it like a comfort, package. It's like one of the orders. So they don't wake up a patient at 4 a.m. to get their vitals unless they have to. Are they using the bathroom? Again, I can't stress enough how important it is for people to be regular. It really is. Are they eating? And also stimuli. This is why it's very important our occupational therapists and physical therapists, we interact with the patient and help them walk to regain their strength. Anything before I move on regarding this? Okay. So yeah, we pretty much talked about this. Now, the one point that I guess Dr. Neal is going to talk about later on throughout the day is this concept of like polypharmacy. We've seen a lot of our patients are on a lot of meds. And one of our goals as geriatric psychiatrists, and we work with geriatric medicine, is, hey, what can we cut out? Does the patient really need this? Because a lot of these medications cause other issues to happen, and they may get prescribed a medication to treat their symptoms. So you basically have a medication over medication and medication. So medication non-adherence, again, if someone misses a dose specifically with psychiatric meds, that could kind of cause some issues. So that's important for me to know. And also drugs and alcohol. Okay. So usually we do get a urine drug screen. So one of the common things is that happens a lot is a patient may get surgery and then they're prescribed, pain pills, and they take the pain pills, obviously because they need to treat the pain. So there has to be that good balance of like, hey, I'm addressing the patient's pain because pain could cause confusion and this delirium. But at the same time, these meds, they could cause a lot of confusion too. And alcohol. We always ask about alcohol, So this is what my thought process is, again, doing that due diligence, making sure everything's good from the thyroid to the heart. And also knowing what the patient's baseline behavior is. Because maybe at baseline, they like wandering, or they're restless, maybe that it's not treated well, and they've been like this for over a year. Then I go, okay, so this is not something new. This is something that's chronic versus something, wow, this just happened within the last 24 hours, 48 hours. I'm thinking more delirium. So when I think of delirium, I'm like, okay, I could treat something to treat this delirium, and it's somewhat reversible versus dementia, which is longer term. So I guess the important thing for us to know here in this room is, so we know the patient's baseline, how they're at home. They know how they are with their ADLs at home, how they are with their caregivers, how they're thinking, if they're violent or they're not violent, if they're wandering or not wandering. So we have a good idea of how the patient is. But then, wow, their behavior completely changes. I'm thinking delirium. What's going on? Let's call the doctor. Does the patient have a UTI, whatever it may be, and then we do our job. Okay, so the delusions component of it. So again, Howard will talk about psychosis in the geriatric population. But some common delusions that you may see with patients who have a neurocognitive disorder is, you know, someone's stealing my money, where's my stuff? Someone stole my stuff. And I hear that a lot. They may think that their spouse or a family member is an imposter, or they're wearing masks. They may feel like someone's coming into the household at night all the time and sneaking in, so they feel like unsafe. And they may feel like they're getting messages from the television, and then, you know, or they may think certain signs in the room is specifically for them. So, or they may feel like their spouse may be cheating on them. So there's different types. Again, this is why it's important to communicate with the caregiver and go, and we do this from a psychiatric standpoint where, you know, this is actually part of the process. It is treatable most of the time with medications. And just so the caregiver feels like, hey, this is part of the process, and they don't feel like, wow, my, you know, family member actually thinks I stole from them. You know, I had a family member who didn't actually know about this or that this was part of the dementia process. And they actually thought like, wow, my family member thinks I stole from them, and they got mad and, you know, they got hurt. Who would want to hear that, right? And one thing, like the fear of abandonment. So that could be normal, right? Where they feel like, wow, I'm a burden. A lot of patients with depression or memory problems feel like, wow, I'm a burden to my family. I'm a burden to others. It takes a lot for people to take care of me. That's like a, you know, and they feel like people are going to leave them or just abandon them. Now, the delusion of that is where it's like, that's, you know, the family members are there. They're taking care of the patient. There's this whole team supporting the patient. But despite that reality, the patient may not understand, and they think like, wow, I'm being abandoned. I've been abandoned. Wow, my family members left the hospital, so I've been abandoned, you know? So that's very distressing for the patient. I've had a patient like this, and where they cry every time their husband left the room. So it was important for us to kind of treat that so the patient doesn't feel that distress. What questions do you have about the delusions? Because this could be the confusing and the most distressing thing for the caregivers too. Howard, what has been the hardest delusion for you to kind of communicate with the family members about, or the caregivers about?
I think usually paranoia is very difficult for family members to deal with. I think it's hurtful for the family members to hear these, you know, odd or bizarre thoughts about them coming from the patient. And at the same time, you know, it's trying to convince the family member to not abandon the patient and to stay involved with the patient's care, even though they feel like this rift dividing them.
So yeah, the paranoia component, that's a big deal, and especially when it comes down to medication. So, you know, a lot of times I hear, wow, my daughter's trying to poison me. I'm not taking my meds. My daughter's trying to poison me, and they may not eat food as a result of that. They may not take their medications as a result of that. Their behavior may get worse as a result of that. And despite like what we call reality testing, where it's like, here, you pick out the food, they'll still be very suspicious and go, you probably poisoned that. Or even if it's wrapped up in plastic or in a container, they may still not refuse the food, right? They'll refuse the food.
In your experience, most of the delusions have a negative impact on patients, or there's any delusion that can be impact positively on them?
Interesting. In terms of delusions being positive, maybe not in my personal experience, I could see, but usually these most delusions, like especially the paranoia one where they feel like people are going to abandon them or leave them, that's very distressing for the patient. Like, for example, like, oh, if a patient thinks their family member is trying to poison them because they have this paranoia, it's distressing because they're like, what food can I eat? What medication can I take? Or whatever it may be. I don't know. I have to think about that if there's like a delusion that may be positive. I don't think so.
He thinks the caregiver loves him.
Okay.
I don't want her to think she loves me. She likes, I can't have her. So it's not negative.
Okay. Well, like, as long as there's not that disinhibition, right, where it gets to a point where.
I just speak with her and let her know, she does that all the time so that, just talk with her.
Okay. Good. Okay. Good. Love, the loved one.
Yeah, I'm asking because I remember one particular case when I was doing an assessment on a participant. We call our participants. So I was asking it was an old lady, and I said, "Do you take your medications every day?" She said, "Yeah, my daughter, blah blah blah." And then she came every day and reminds me about my medication. So the other daughter who was in the assessment says, "Oh, my mom is losing her mind because my sister is dead. She passed away years ago. But she insists that she comes and remind her about the medication." And I was like, maybe she's like misplacing the person. Like the one she's reminding is this one, but she thinks it's the other one, or she sees the other one. That's why I'm asking this question.
That could be common where they may think one person's another person. And sometimes it's possible where some of the patients may think that their relatives from the dead are there and they may see them, believe that they're there. So that may be comforting, for instance, where it's like, oh, they feel like their ancestors are with them or something along those lines, versus where, it may not be, it could be scary, right? But yeah, that's interesting. The mind is very interesting, and the more we explore and investigate about these, what we may say is delusions or whatever it may be, is interesting. Yeah. And you had a question, and
just wanted to ask, what do you recommend family members to do in those cases? I have a patient. You were describing her paranoia, obviously afraid, or feels that family is going to poison her with medication, so she refuses everything. She's even kind of isolating herself, not wanting family to be involved with her care. She wants nothing to do with anyone. So it's really hard to get her to follow any of her treatment plan. So what could we do in those cases? We've tried PERT. She goes in the hospital, she'll be medicated, she stabilizes, comes back home, goes back to square one, refusing to take any meds. So it's very challenging.
So that is very challenging, and we don't want it to get to a point where they don't eat or take any meds, where they get so bad where they have to go back to the hospital, right? Again, and it's just like this cycle. So I think this would be a good question for like the patient's psychiatrist or medical doctor, specifically the psychiatrist, because it is like this paranoia. Where what type of meds is the patient taking? Is the medication dissolving in their mouth? Is it like a powder medication? Is an injectable an appropriate medication for the patient? So those are good questions. But yeah, I would figure that out, because I wouldn't want the patient not to eat for a very long time. Then their kidneys get damaged because of that, or something, like they're dehydrated, and then they get hospitalized, and hospitalization leads to more morbidity and mortality. Like their quality of life is going to go down. So if I could prevent that, and I've had patient cases like that where I've prescribed dissolvable medications, and sometimes patients who are very, very, very paranoid, there is medications where you could give an injectable of an antipsychotic to help with the paranoia, and that lasts like a month.
The thing with her is that she won't go to appointments, so a psychiatrist has not even been able to see her.
Okay.
Getting her to participate in some way.
And has this patient ever been in a psychiatric unit? Okay. And so you and I could talk more. I'd be happy to get more information to give that advice.
Okay.
But I think, again, like red flag, if they're not eating or taking their meds, I think they should at least do a video visit or something along those lines, or call 911 and take the patient, because I wouldn't want the patient to get worse. Yeah.
Thank you.
Yeah.
I was just wondering if there have been any studies done on patient populations that have a very early diagnosis of dementia or Alzheimer's or whatever the diagnosis is, and if they're given this level of education, like this is potentially what is coming, right? Versus the population that gets no, you're going in this direction, delusions. These are some things that you may experience and have a family member there, so there's a level of education that's done initially. Have there been any studies like that? And is there any carryover? Is there any difference? Or, does that make sense?
Yeah, no, that's a very good question. So there are studies like that. There's a lot of prospective studies and even retrospective studies that look at when dementia is diagnosed and what symptoms the patient may have had. I could look into the literature to see what educational interventions were done, but I could speak from personal experience with my patient population, where if we do assessments now regularly for the geriatric population in regards to cognitive assessments, MOCA, or a mini mental status exam, which basically tests different parts of memory, short-term memory, executive functioning, whatever it may be. So let's say I see someone has there's a mild cognitive issue. And the patient, they're still able to drive, make their appointments, do whatever they need to do. Then the option, I may get head imaging or whatever it may be, have that discussion of, do you need to be on a cognitive enhancer, like the Aricept, donepezil, there's a lot of them, because that could slow the progression down. Or are they depressed? I go through my workup, no thyroid problems, whatever it may be. Let's say I did have all of that, right? And they don't meet criteria to take a medication. Yes, I tell the family and the patient, these are things that you may experience, and here are the red flag symptoms. Similar to what you and I were talking about, which is like, okay, if there's more social withdrawal, they're not eating as much, it could be depression, so let me know. That's very common to have memory problems and depression at the same time. That's treatable. Come back in. Or red flag symptoms, the delirium thing we just talked about. So they're doing okay, they have some memory problem, but they may get a UTI and we don't know about it. And then they become like very agitated, combative, suspicious. Okay, red flag symptom, come to the hospital. So let's say someone does get that diagnosis of mild cognitive impairment and it's not at the moderate or major stage, and I still don't know if it's Alzheimer's or this type of dementia versus that. I want to see the patient every 4 months, 5 months, 6 months, whatever the issue may be, and then see what's going on. And always keeping in touch with the family, just so we're all on the same page. Because if we could tackle something early, let's do it. But yeah, if you'd like, I could do a literature review. And if you'd like, email Bianca, and I'm happy to email back. Yeah. Any other questions or any patient cases or personal like obstacles experienced with patients with these delusions, paranoia? Okay. Now, again, another doctor will talk about medications. But a lot of patients are on a lot of medications, and these medications may have side effects. Some medications they need to take daily. So we could go through like one problem right here. We talked about the opioid use, right? So opioid, you need to have that appropriate balance. Am I treating the pain? Versus, wow, they're overly sedated. People take pain pills, the opioids, it causes respiratory depression. They may not be able to breathe. They may suddenly stop breathing because of that. That's horrible, right? Also, some opioids are neurotoxic. So that could cause memory problems like impairment. Even something like a Benadryl, which is considered something called anticholinergic. Basically, you don't pee as well, you don't use the bathroom as well. it dries you up. That's basically what anticholinergic is. That could cause confusion. So I need to look at the patient's med list and go, hey, what's causing this? A lot of patients take like seasonal allergy medicine that can make them more confused. So that's what I do pretty much some of the time. I look at the list, see what I could remove, what I could tell the family members not to give. Or if they're taking a water pill, right? You know, to use the bathroom, the Lasix, a diuretic, just so they could go. Let's say they have heart problems. Maybe not taking that at night so they don't wake up 3 to 4 times a night so they don't pee, because then they're not going to sleep well. And if you mess up sleep, you mess up a lot. So again, sleep is key, even for us, you know? So I'm not going to go through this, but there's something called the Beers list that they came up, which is like a list of medications that affects the geriatric population. And in regards to placement, I feel a lot of facilities are going to say like, hey, why is this patient on this med? Is it possible if we get this patient off this med? So a lot of these facilities will tell you like, hey, tell the doctor like, this is a no-go. Like, why is this patient on this med? Okay. Now, again, Dr. Howard will talk about this, but again, I just want to make that point of what we do from a geriatric psychiatry side. I did everything, right? Like I went through every organ and I saw, okay, there's no medical problem. That's the only time I'll start thinking like this is a pure psychiatric problem. You could have 2 things at the same time, but again, it's very important for me to go through all the medical stuff. Okay. So, yeah, again, we went through a lot. Talked about dementia. We talked about delirium. We talked about red flag symptoms. We talked about the behavioral psychological symptoms and problems. What we do as team members to get that data and what the doctor does, and what conservative, simple things we can all do to help the patient. Noise, hunger, bathroom. I think I've said bathroom a million times, but trust me, it's key. Okay. So yeah, we've talked about this, and I think this is very challenging as well, talking to the caregivers. So from a, I guess, psychological perspective, so it's really hard for someone to feel like they're not in control of a situation. It's really hard for someone to go, wow, this was my loved one, and now this is where they are at this time. Or being a professional and you're taking care of a patient, and then their behavior could be challenging to navigate. That's very distressing for us. So don't forget to think about yourself or what we can communicate to the caregiver. This is emotionally exhausting as well. So make sure you communicate with your peers or like your supervisors. And that's what we do as psychiatrists. It's called like a supervision. If I feel like I had a hard patient interaction or a hard experience, I always talk to a colleague and or supervisor, because that prevents burnout. Just processing that prevents it. So talk to someone you trust. And that's exactly what I'd tell the caregiver too. I want to maintain that open dialogue so they could reach out to me, so I could talk to them and kind of walk through and help problem solve and troubleshoot. So also, again, going back to that gentleman's question, that educational component is so important of what may happen, what may not happen, and this is when you should go to the hospital or the red flag symptoms. And that last component, which I mentioned before, that emotional capacity. People still, they may not be able to communicate as well as they may want to, but that they still feel that distress or sadness or that indifference. It's really hard to not remember that, because if someone's not cognitively there, they may not be able to communicate like, wow, I'm anxious, I feel crappy. So we may forget, unfortunately, as the more people we see, but we'll keep that in the back of our heads, that there is that emotional component. Okay. Oh, speaking. So this is very important too. So I have to like check myself a lot because I speak fast. And I always ask, hey, does the patient have a hearing aid? What ear do they hear better? And already my patient comes in and tells me like, hey, I can't hear well from this ear. So I already like position myself. And you don't need to speak that loud or anything. That's kind of annoying. So I don't do that. So I speak with good diction just to enunciate the words. And it doesn't have to be really slow either, as long as you're properly saying the words. And if there's still that communication barrier, I write it out. And this is why it's also very difficult for me to have video visits to see patients. That's why I want to see them in person. So I see why that could be a challenge for some of our patients. Okay. Okay. Care refusal. Have you all experienced this? We've talked about this with your case, but any difficult, cases that you've all had where the patient refused care and that's impacted how you're coordinating the patient's care plan? Or has it been challenging to communicate this with the family? It happens. It's going to happen. And if they refuse care, let's say the caregiver is like, I don't want anything. That could be one case scenario. Let's say it's not the patient. Ultimately, it's our due diligence to give whatever resources we can to help the family. Ultimately, my job as a psychiatrist is to do my assessment, offer these resources or treat whatever I could treat. But if the family and the patient's refusing and assuming they have that capacity to refuse, like they have they're thinking and communicating appropriately, I will provide them that resources as long as I'm opening up that door where they could come in anytime that they want. So maintaining that good therapeutic alliance. Okay. So we've talked about these environmental stuff. Okay. And again, Dr. Neal will talk about the medications in more detail. So I'm not going to talk about the benzodiazepines here. But I do want to make a point, like benzos, you'll see a lot of your patients are on Ativan or Xanax. And just the key thing to remember that it does worsen memory, causes patients to fall. It does help with anxiety, but there are other medications we could give our geriatric patients to feel less distress. I think the important thing here is if a patient's taking a benzo, Xanax, and Ativan, and a pain pill, I'm like, oh gosh, because both of them cause you to stop breathing as well, and a lot of patients may have sudden death as a result. So that's the red flag thing I'm looking for.
Is that on the beer says?
Yes, it is. Mm-hmm. Yeah. Okay. So again, this DICE evaluate and re-evaluate, going from what's going on with the patient. We address the medical issues. We've addressed the psychiatric issues. What's delirium? We've talked about that, where it's like an acute change. But if things are not getting better or things are getting worse, it's important to note that this, unfortunately, may be part of the dementia process. Okay, so that's important to keep in mind and educate the family as well. Okay, so again, now, I think before I talk about the different types of dementia, I think we could take like a 5-minute break. So I'm just gonna review like 3 important things, and I'll use the last portion of my time just to answer any questions. I thank you for the individual questions you all asked me. Again, you can contact me, or if you want to discuss or use me as like a consultant to help out with difficult cases, I'm more than happy to assist with that. Just let me know, okay? So Just gonna, before we start, any questions or anything that you'd like me to address before I start? Good. Okay, very good. So again, Alzheimer's, I just want to make a point, there's different types of dementias. And based off those different types of dementias, you kind of get different types of memory problems if I really had to tease it out and look into the different symptoms. But again, the most common one that we may see in our patient population is Alzheimer's disease. The course is long. We saw that chart. They may start off with depressive symptoms and then get some memory loss, and it kind of goes down from there. But patients with Alzheimer's, when they, whether it's moderate stage or severe stage, I kind of use the activities of daily living to kind of figure out like how is this affecting the patient or what stage they may be at. Because if someone's unable to eat or swallow properly, the food may go down the wrong pipe and they may get like a pneumonia. That's a big deal in that. They could get hospitalized. So again, activities of daily living, that's my big assessment. Like I keep that in the back of my head. So yeah, a lot of complications from Alzheimer's. This is what this slide is basically trying to say. So let's say it's mild, early stages, they're still able to do certain IADLs. Again, maybe call the doctor, make an appointment, drive, go out, pay their bills. They may be forgetful. So they may start misplacing things. That's where it kind of starts off with, right? Misplacing their glasses, hearing aids. Then they may start forgetting appointments or dates. That could be part of the normal aging process. This is why at that point I'd reinforce, have a calendar or here's some conservative things we could do. And then they may forget where they live and it progresses from there. But again, activities of daily living and independent activities of daily living, basically how independent one can be, changes from stage to stage. Moderate stage. Again, this is not definite. Again, it's about taking everything, seeing where the patient is, seeing where the family is. I don't really need to say like, wow, this is early versus moderate versus late. If someone's going through this cognitive process, what can I do to help the patient and family out? But I think this is a good way to kind of break it down just so it demonstrates the progression. So moderate stage, they may have problems with finances. So an IADL, independent activity, daily living, executive functioning, and then other things that may impact their functioning. If they're not able to drive anymore, they're not going to go to their doctor's appointments, or they may not see their friends. That may make their depression worse. So it affects the patient. Late severe, again, they're unable to do their ADLs. So a lot of the patients we see on our psychiatric unit at the Senior Behavioral Health, maybe at this stage, because they need assistance with potentially eating, dressing up, taking their meds, being reminded to take their meds. They may not even be able to swallow appropriately. Okay, so we did talk about these support and educational resources and what we can do to support the patient. And here are some resources. It's in the slide, and the slides will be emailed out, and I'm sure you guys have better resources than I do. PACE is an amazing program. We wish all our patients had like a PACE supporting them. And again, safety. I just want to touch on this last point. I always ask the family members and patient, did the patient leave the stove on? Is the patient driving whenever their license may or may not be revoked? Because it is a danger to public safety. I've had patients who leave the stove on for hours, and that could obviously lead to, very bad consequences. I always ask how the house is built. Is it 2-story houses? If there's stairs, is the patient on the first floor or the second floor? Are there rugs on the floor? If there are rugs on the floor, maybe we want to remove them because if they're loose, they're going to fall. Are there pets in the house? Want to make sure the patient doesn't trip over the dog. That stuff happens. Appropriate lighting and firearms. Are the firearms locked? Are they unloaded? Is it away from the patient with a memory problem, with a terminal memory problem? Okay. So again, safety is key. I always get that down. Likewise with these other things. The bed height. So that's where our PT and OT team, physical therapy and occupational therapy team helps us out as well. What's appropriate for the patient? How are they able to walk, transfer from point A to point B? Okay. So we pretty much covered everything. We did cover everything. So everything else is just extra information about the different types of care or facilities a patient may go to. But in terms of objectives, I think we covered what we needed to cover. What's dementia? What's delirium? What do we do as psychiatrists, and what we can do as a team to support the patient and caregiver? Okay. What questions do you have? Okay. Thank you. Yeah.
Concerning diagnostic tools for Alzheimer's, dementia, as opposed to psychiatric disorder with a late onset.
So the question was about being diagnosed with Alzheimer's disease with or without some psychiatric issues versus like, oh, is this just a psychiatric issue all by itself? So that's very good, and that's part of our assessment. So getting that baseline, how is the patient like before all of this started? Like what is considered, quote, normal, right? So let's say the patient was functioning well regarding with their ADLs, IADLs, they weren't paranoid, they weren't depressed, family members said things were going okay, but they started misplacing things, and then they started forgetting appointments, it became more difficult for them to drive, and there's this progressive pattern. I do my due diligence, go through that workup, thyroid, brain imaging, whatever it may be, heart, literally every organ. And then let's say I do my psychiatric assessment and they're not depressed, they're not psychotic, they're not anxious, there's nothing else going on psychiatrically. I feel more confident to say, hey, this is a neurocognitive disorder. I don't know if it's Alzheimer's yet though. I won't know. It's really hard to, but there is a dementia component, and there's again different types of dementias. Now, you could have two things happening at the same time. Someone could have a neurocognitive disorder, and then they could have a psychiatric issue. And I think, again, the hard one to tease out is, wow, someone's depressed. Depression causes cognitive issues. It's really hard for people to concentrate, think, and even remember. I don't like this term, but sometimes people call it pseudo-dementia, where you may be more forgetful because of depression. There's like this inflammation in the brain, and it's hard for people to concentrate and do things, versus, wow, they're having a neurocognitive issue. But two things could happen at the same time. Yeah. Very good. Anything else? Okay. Thank you, everyone. This was good. We did this early in the morning. I'm like proud of all of us. Like we're really, and all of you like seemed really like, okay, thank you so much. You made me feel really like, this is worthwhile. So I appreciate your time. Again, I'm available. If you need any questions or anything I could be helpful with, please contact me. More than down to help, okay?
Thank you.
Thank you very much. Thank you.